Good evening. I'd like to welcome you all to our Weinberg Family CP Center webinar entitled Bridging the Gap from Hospital to Community, Collaborative Care for the Postoperative Patient with Cerebral Palsy. I think we have a terrific program for you this evening. We're going to talk a little bit about orthopedic surgery, and then we're going to talk a fair bit about physical therapy for these patients. We have a terrific panel. And I think what we will do now is just get started. Myself and Dr. Selber, my pediatric orthopedic colleague, are going to begin by talking about the orthopedic care of children with cerebral palsy. I'm going to talk about the care of the non-ambulatory child, and he will talk about the care of the ambulant child. And then we're going to hear from our physical therapy colleagues. So to start, I'm going to share my screen with you. And bring up my slides. Terrific. So I am going to speak with you all about the orthopedic management of the non-ambulatory child, what we do, and why we do it. These are my disclosures, none of which are really relevant to this talk. So whom are we talking about? When we speak of non-ambulatory children, we are really speaking about GMFCS level 4 and 5 children. You're all familiar with the gross motor functional classification system, and it's a progressive system from level 1, which are the most functional children, to level 5, which are the least. Level 4 children are non-ambulant. They do not walk independently, but they may be able to take some steps with maximal assistance, and certainly can assist with standing for transfers. So what are we talking about? Well, we're going to talk about hips, we're going to talk about knees, we're going to talk about feet. For hips, what these children need are mobility. They need their hips to be stable for seating, and they need their hips to be mobile enough for proper hygiene and dressing. The knees need to be mobile-ish. They don't need to have full mobility, but you certainly want to avoid any flexion beyond 90 degrees, which then would make it difficult for seating, as well as extension contractures of less than 90 degrees, because then it can also make it difficult for seating if their legs are stuck up in the air. And the feet also need to be a little mobile-ish, but most importantly, they need to be plantar grade and stable for standing. We also would like them to, the other reason for being plantar grade is that we do not want them to have to bear weight on the top of their feet. That skin is not intended to bear weight. It's generally thin and can lead to skin breakdown, wound problems, and infections. And of course, most importantly, we want the children to be free of pain. The natural history of hips in children with GMFCS level 4 and 5 cerebral palsy is that of displacement. This begins at a young age, and it begins silently. It's not painful, and it really doesn't generally cause much in the way of disability. However, as I say, it does progress to gradual dislocation. And once the hips do start coming out of the socket, there really is no way to prevent it without intervention. And here you just see a natural progression of a child, first at 11 months with nicely formed hips, and over a couple of years, they slowly begin to migrate out of the joint. So early identification of these children and of their hips is critical. GMFCS is quite helpful in that it predicts the likelihood of dislocation. Children that are GMFCS level 1 rarely will have any hip problems, and children that are GMFCS level 4 and 5 frequently do. And it's can be up to 75 to 80% of these children will go on to have hip displacement. Again, the reason that we're concerned about these hips is because they do eventually cause pain and can cause difficulty with mobility, seating, and general care. If we delay the detection, if we don't recognize that these hips are coming out of joint and they do eventually dislocate, then we it requires greater intervention to correct them. So early detection can prevent dislocation as well as deformity and pain, and it has been demonstrated in multiple studies now to be not only possible but critical. The mainstay of this hip surveillance is the physical exam. We want to focus on spasticity, making certain that the children do have reasonable mobility. Pay attention to their pain. Worsening pain is often an indicator of displacement. They can have worsening sitting, standing, and walking ability. And then you as therapists will certainly be able to recognize changes in both their passive and dynamic range of motion, assessing hip flexion extension, adduction, abduction, internal and external rotation, as well as the overall positioning of their hips at rest. So what can you do? Well, first of all, be aware of the issues around hips in children with cerebral palsy. Begin surveillance when you first encounter the children. So surveillance really should begin in infancy or toddlerhood. Though these children need to be evaluated at an early age. Monitor any change in their pain or discomfort, and then know when to refer. And that would typically be when there are significant changes in pain, discomfort, function, or range of motion. And again, always listen to the parents because they often are most attuned to these changes. Hip problems in children with CP follow this continuum from having essentially a normal hip, or what we might call a hip at risk in a child with significant spasticity, to subluxation, where the femoral head is just beginning to come out of the joint, to frank dislocation, and then dislocation with significant degenerative changes. Depending upon where the hip is in this continuum, our interventions will change. Early on, we can often get away with just soft tissue surgery to try and protect the hip. Once the hips start to come out of the joint or come out of the joint completely, we can employ reconstructive measures to put the hip back in place and reform both the acetabulum and the femoral head. Unfortunately, once the hip is completely out of the joint and has begun to deteriorate and become painful and stiff, we really don't have much in the way of reconstructive options, and we're left with salvage surgery. And we're going to talk a little bit about each of these. Early on, the mainstay of soft tissue surgery are tenotomies, adductor tenotomies and psoas tenotomies. These typically are done in younger children who are beginning to develop some stiffness of their hips and have mild subluxation. This may not avoid the need for more extensive surgery, but it can certainly delay it until the children are older. It will slow the progression of the dislocation. Post-operatively, we manage these children with bracing, not so much casting any longer. Typically, it's bracing. Certainly, physical therapy is critical, and you're going to hear a lot more about this. And the goal is to restore and then maintain their range of motion. It's also critical to recognize, of course, that these hips are still a work in progress, and that surveillance is critical going forwards. This is a child who is farther along in the continuum, and you'll notice that the right hip is already dislocated and the left hip is about halfway out of the socket. She is GMFCS level 5, and her parents have noted difficulty with dressing and hygiene. However, she's not yet having any pain. We employed a reconstructive treatment, and comprising extensive soft tissue releases to neutralize the deforming forces. So we released the adductor tendons. We did a psoas release as well. And then we changed the bony anatomy. We did a femoral varus shortening and derotational osteotomy to reshape the femur and get the femoral head pointed into the acetabulum. And we also reshaped the acetabulum to give the femoral head a better socket to reside in. Afterwards, we want to begin immediate range of motion in the hospital. Post-operative pain management is critical. These children typically will be managed with epidural catheters. Once they leave the hospital, again, it's critical to maintain their range of motion. And we will usually begin weight bearing at about 4 to 6 weeks. This is a child who is beyond the reconstructive scenario. This boy is 13 years old, again, has is GMFCS level 5. And at this point here, you see where the hip is degenerated, that the head is no longer round. He is having significant hip pain and difficulty with seating and dressing. We do not have a good reconstructive option for these hips. What we typically will do is remove the femoral head and perform a valgus osteotomy to get the top part of the femur away from the pelvis, no longer in contact, and remove the, that pain generator. Some people have employed total hip arthroplasty in these patients, as well as hip fusions, but the success is not as good. So this is what it looks like at proximal femoral head resection. We've removed the head, done this large valgus osteotomy. We can point the lesser trochanter into the acetabulum. You'll cover this up with soft tissue, and it creates a very nice, mobile, pain-free hip. So we'll move down to the knee. Most common problem at the knee are contractures of the hamstring muscles. However, you can also have spasticity of the rectus, which would lead to knee stiffness. Knee pain is quite common in people with cerebral palsy, particularly as they get older in adolescents and young adults, and it is all related to this abnormal tone. The patella will come out of the joint. It can either, you can either have patella alta, where it's too high on the femur, or it becomes unstable and can slip out side to side. And sometimes the forces are so great, it can actually cause fragmentation or fracture of the patella. The important thing to recognize that if you're ambulant, if you are able to walk, what you really need are straight knees. But sitters need bent knees. So we don't need to make these knees completely mobile and straight, but we do need to keep them in a position that is functional, which for a sitter would be bent, but again, not too bent, not beyond 90 degrees, because then the knees, their legs come up underneath the chair and blocks their ability to sit. Early on, we can employ some non-surgical options. We can treat the knee flexion and extension contractures with serial casting, with or without Botox. You need to be careful and do this gently. You want to avoid any neurological injury, because of course the sciatic nerve resides right behind the knee and can often be stretched unintentionally. You can also cause instability of the knee joint and get subluxation. And if this is done with casting, you can develop pressure ulcers. But if you do it gently, you see you can have actually quite a nice result. Once the contractures get to be too great, they have pain, and then they develop difficulty with sitting, then we have to employ surgical measures. These tend to be soft tissue lengthenings. For flexion contractures greater than 90 degrees, we'll do hamstring lengthenings with release of the semitendinosus and gracilis muscles, and then recessions of the semimembranosus muscle. If the problem is more of an extension contracture, then we can do lengthening of the quadriceps tendon. Again, afterwards, we will brace these children to maintain the new alignment and initiate range of motion right away to keep their knee moving. Once they leave the hospital, we'll usually use a night bracing regimen and, of course, maintain their range of motion. And if they were able to bear weight before surgery, we'll get them up on their feet very soon after this, usually within the first week or two when pain allows. Lastly, feet. So what's important for the feet? As we said earlier, it's important that they're able to stand for transfers, and also that when they are sitting, the feet are resting comfortably and plantigrade on the footrest of their chair. We can do this when with soft tissue procedures when the feet are flexible. We can certainly lengthen the Achilles tendon. There are numerous methods by which we can do this. And we can also transfer tendons that are pulling in the wrong way to another location so that they can then pull in a more beneficial way. And afterwards, again, they would require bracing and therapy. Lastly, when the feet become rigid and stiff and painful, we have to then employ osteotomies to cut and reshape the bones. and sometimes also fusions to keep them in this newly aligned position. The goal, once again, is a stable, braceable, plantigrade, and painless foot. So I'll stop here, and I'm happy to entertain any questions that the audience might have.